Well, hemolysis does have some new things into it, but the thing that is not new is that every form of hemolysis causes you to have an increased reticulocyte count, an increased LDH, an increased reticulocyte count, increased LDH, increased indirect bilirubin. But if the hemolysis is intravascular, the things that will be different is that you will see not just an increased bilirubin, okay? If it's intravascular, you will see not just an increased LDH, not just an increased reticulocyte count, not just a decreased haptoglobin, you'll also see schistocytes and helmet cells. Schistocytes, helmet cells, and fragmented cells. DIC-TTP, hemolytic uremic syndrome. DIC-TTP and hemolytic uremic syndrome will give you a positive smear with intravascular hemolysis, also known as fragmented red cells. Now, which form of hemolysis shows bilirubin in the urine? None of them show bilirubin in the urine because the bilirubin that gets released in hemolysis is indirect bilirubin, and indirect bilirubin is glued to your albumin. So you don't see any form of the hemolysis with bilirubin in the urine because if it's attached to albumin, it doesn't filter at the kidneys. So none of them will have bilirubin in the urine. Now, when a man comes with several hours of chest pain and sickle cell disease. Sickle cell disease, we love sickle cell disease because sickle cell disease will have about 8 standard questions. What's the best initial test? What's the most accurate test? What's the best initial therapy? Right? It has severe chest, back, thigh pain. Why do you get cholelithiasis and gallstones with sickle cell? The gallstones are from bilirubin stones. You get osteomyelitis from what organism most commonly? Yes, it is Salmonella. I don't say that to you lightly. You can repeat what I say on your test. What happens? You get the test day and you're like, oh my God, I don't believe Conrad Fisher. What should I answer? I want to say Staph aureus, but he told me it's Salmonella most common. It is Salmonella. And Staph aureus is just not the most common. Period. What's published. Aseptic necrosis, because the cells infarct the bone. Here's the key issue. There's no fever. No fever. Fever automatically by itself means antibiotics because patients with sickle cell disease get wiped out with sepsis. Why the fever just alone means antibiotics? Because there's no spleen when you have sickle cell disease. So ulcers on the legs are part of sickle cell disease. So seeing ulcers on the legs should not alarm you. And the saturation is important because desaturation increases the likelihood of sickling. The best initial test to confirm that someone has sickle cell disease, electrophoresis is the most accurate test, telling you the amount of sickle hemoglobin. Bone marrow biopsy doesn't show anything with sickle cell disease at all. Reticulocyte count is up, but reticulocyte count is up with any form of hemolysis, not just sickle cell disease. Peripheral smear will show sickle cells. So what? LDH and bilirubin are elevated in all forms of hemolysis. Well, then what's the answer, Conrad? The smear. The smear. The best initial test for sickle cell disease is not the electrophoresis, because you can see here that there are sickle cells on the smear. There's a sickle cell, there's a sickle cell, there's a sickle cell. Can the peripheral smear tell you the difference between sickle cell disease and sickle cell trait? The answer is yes, although you'd be amazed at how many people say no. Smear can't tell you the difference between disease and trait, but it can tell you the difference in between disease and trait, because sickle cell disease has sickled cells. Sickle cell disease has sickled cells, and what do you see in a smear with trait? This is what you see. Nothing. See that blank screen? You don't see anything with trait. Trait does not give you an abnormal CBC. There's basically only one injury to the body organ that you get with sickle cell trait, also known as the heterozygote, also known as AS disease. The heterozygote or AS disease only has damage of the kidney. The most accurate test for sickle cell disease is the hemoglobin electrophoresis. But that's the same for any hemoglobinopathy. Thalassemia, thalassemia A, thalassemia B, hemoglobin electrophoresis. The best initial step in the management of this patient. Well, there may be the best initial test is a smear, the most accurate test is an electrophoresis, but this person has no fever, and doesn't say an infection, so no ceftriaxone. Hydroxyurea is not used acutely. Hydroxyurea is used to prevent the next crisis. Hydroxyurea is like your cromolyn for an asthmatic. Folic acid should be given to everybody with sickle cell disease because they have a chronic compensated hemolysis. Chronic compensated hemolysis. However, it's not the most important thing to do first. Since sickle cell hemoglobin mostly sickles under conditions of tissue hypoxia, giving oxygen is good. Dehydration, also. Dehydration, hypoxia, infection, acidosis are the three main things that predispose to a crisis in sickle cell disease. Dehydration, hypoxia, infection, acidosis. And pain meds because they're in pain. So antibiotics will be indicated because of obvious infection, but even without a clear infection, even without fever, cough, and sputum, even without frequency, urgency, burning dysuria, just because of having a fever or a white count higher than usual, you give antibiotics. Because a white count tends to be like a fever. What do you do for a fever evaluation? I get a urinalysis, a chest x-ray, and blood cultures. Fever evaluations, a urinalysis, a chest x-ray, and blood cultures. Well, what do you do if the white count is 30,000? Urinalysis, chest x-ray, and blood cultures. Now, because people with sickle cell routinely have white counts of 12, 14, and 60,000, routinely because their marrow is hyperexcitable, routinely it would be a person who usually might have 12 or 14,000, now is at 24 and 28,000. So it's a white count higher than usual, which indicates the same thing as a fever, which is the possibility of an infection in a person who has no spleen. And what will you use? You will use what looks like what you would use for community-acquired pneumonia, ceftriaxone or cefotaxime, a respiratory fluoroquinolone, levofloxacin, gatifloxacin, levofloxacin, gemifloxacin, moxifloxacin, because they cover pneumococcus and Hemophilus, which are the encapsulated organisms, because there is no functional spleen. All adults with sickle cell disease are functionally asplenic. If there's a fever or a white count higher than usual, if there's a fever or white count higher than usual, okay, now you'll give antibiotics that cover pneumococcus and Hemophilus. Ooh, the other encapsulated organisms. Do these guys cover Klebsiella? They do. Yeah. Do they cover Salmonella? They do. They do. Several hours after starting therapy, the patient develops shortness of breath, worse chest pain, hypoxia, and a new infiltrate. That's acute. You've got acute chest. That's such acute chest syndrome you've got. What are you going to do for this person? Ooh, eye problems when you infarct your eye. Exchange, transfusion, exchange, transfusion, exchange, exchange, exchange. Lung. Infarcting my lung. Exchange, transfusion, exchange, transfusion. Whoa. Malignant hypertension of the penis. Malignant hypertension of the penis, which is priapism. So, eye, lung, penis, and brain, stroke. Eye, lung, penis, and brain, exchange transfusion. How do you get rid of the sickle hemoglobin? You see, I hate, sickle cell is one of the hardest diseases personally for me to take care of because you get patients who say they're in pain and you're not sure if they really are sometimes. And I don't like being in the criminal justice system. So the question comes down to, what if you're not certain and you're giving them pain meds and they go like, no, I want more, I want longer. You can transfuse them. And when you transfuse someone a couple of units of blood, you've effectively diluted out the hemoglobin, their sickle hemoglobin, with 10 or 20 or 30% normal hemoglobin. For instance, if you have a person that normally has a hematocrit of 25 and you make it now a hematocrit of 30, a 5-point rise is 20% of hemoglobin. That means the crisis should end. So transfusion should end a sickle crisis. An exchange transfusion is when you have to do it in a super hurry because they're infarcting their eye, lung, penis, and brain. Eye, lung, penis, and brain. The following day or two, the man's hematocrit has a big drop. That's an 11-point drop. There's a big 11-point drop in the hematocrit. Where did our blood go? So there's two choices here. One is saying that it's folic acid deficiency. The other, what's the other thing that has sudden drop in hematocrit in a person with sickle cell disease? Folic acid deficiency and parvovirus B19. Parvovirus. The best initial test for parvovirus, IgM is good. Reticulocyte count will be high or low. What will the reticulocyte count be? Ooh, let's go back. Parvovirus freezes the bone marrow. So if you freeze the bone marrow, the first thing that changes is that your reticulocyte count should drop. Because remember, what's the usual reticulocyte count in a person with sickle cell? Well, like all people with hemolysis, the usual reticulocyte count is high. So if parvovirus or folic acid deficiency freezes the marrow, the reticulocyte count should go down. But the reticulocyte count being low, because remember, you're expecting high and parvo freezes the marrow, it's not as specific as PCR for the parvovirus DNA. Now, there's parvovirus B19. What's parvovirus B18 and 20 doing? There is no other parvovirus. There's no parvovirus B18 or 20, no A19. It is parvovirus B19 alone. And to treat that parvovirus, you use intravenous immunoglobulins. Intravenous immunoglobulins if you have severe anemia. Parvovirus, you ready? Sudden drop in hematocrit in someone who's got a hemoglobinopathy. Best initial test is to confirm that there's no reticulocytes anymore because the marrow is frozen. PCR is the most accurate test, and if you've got bad anemia, you're going to use intravenous immunoglobulin. The following day is all better, and he's going to be discharged in hydroxyurea. How do you know if he's getting enough hydroxyurea? And the wrong answer will be waiting to see if he develops a crisis. We're not going to wait to develop if he develops a crisis. How is he getting enough? You're going to be able to look at the person and determine if they're having, no, it doesn't have effect on reticulocyte count. It doesn't affect platelet count. Waiting for crises is not good enough. The way that hydroxyurea works is it works by increasing the level of hemoglobin F. And hemoglobin F, when it goes up, dilutes out the sickle hemoglobin so that the sickle hemoglobin doesn't sickle as much, because once you get up to 10 or 15% hemoglobin F, it won't sickle as much. So if you can get up to 10 to 15 to 20% hemoglobin F, you won't sickle as much. But as you're raising the dose, what's the toxicity of hydroxyurea? Hydroxyurea will affect, won't do bone lesions, blast won't do there. What it will affect if you're getting too much is it will drop your white count, because it'll be marrow toxic because it's dropping your white count. A patient with sickle cell disease had sudden hip pain. Why did it happen? Osteomyelitis is not sudden. Bone infarct it can be. Sickles don't get bursitis. Sicklers get aseptic necrosis. And we don't know exactly why. Is the hip a low flow, low oxygen situation? Well, I don't know. I suppose compared to the lungs, maybe. But what ends up happening is you get aseptic necrosis. The cells in the bone just die. And you get asymptomatic necrosis of the femoral head. 20-year-old man is on hemoglobin electrophoresis, has trait. What's the only thing that's going to happen on smear and CBC? Nothing on smear and CBC. But what you will find out what happens is that people with sickle cell trait have kidney problems. They can't concentrate the urine. So it's urinated out at the same strength as the blood. Isostenuria. People with sickle cell trait don't infarct their eyes, don't infarct their spleen, don't get osteomyelitis, and they don't have enough hemolysis because sickle cell trait is hematologically normal. So all you get is hematuria, isostenuria, and hematuria, red cells, and you start to be able to infarct the kidney, damage the kidney tubules enough that the kidney tubules can't concentrate the urine. They can't concentrate and they can't dilute. SC, hemoglobin S combined with hemoglobin C. SC. SC gives more crises than a trait, but less crises than sickle cell, homozygous sickle cell. The major difference between, got that? SC is halfway in between. more crises than trait, but less than homozygous SS disease. The biggest difference between SC from the others, SC is characterized by fewer crises and visual disturbance. Hemoglobin SC gives a problem with your ability to see. So that's what's most unique, which is the visual disturbance. Everybody who has sickle cell disease can get splenic infarction, and they do. Renal involvement, hematuria, isostenuria, osteomyelitis, most commonly with salmonella, with Staph aureus, bilirubin gallstones. But SC disease is more likely to give you visual problems. Two heterozygotes want to know what is the chance that our child will have sickle cell disease, not just the trait. 25% of the children from two heterozygotes will be normal. 50% of them will be carriers. There will be AS people. They'll be carriers carrying the trait. 75% is nothing, and nothing is 100% except death and taxes. So in the same way 25% will be normal, 25% will also be homozygous for sickle cell disease. 25% normal, 25% homozygous for hemoglobin A, 25% homozygous for hemoglobin S. A patient with sickle cells going for major surgery. This is now a memorizable fact. What are you supposed to be able to bring up the hemoglobin to? What target? The hemoglobin should be above 10. And it's a memorized fact that you just have at least 10 grams of hemoglobin to keep your body alive. Period. Just using a memorization. Which of these causes an increased hemolysis? Does copper cause hemolysis? Zinc? Folate. Folate doesn't cause hemolysis, just causes a production problem. B12 doesn't cause hemolysis, causes a production problem. And even though it's ineffective erythropoiesis and the bilirubin is down, the bilirubin is up, the LDH is up, it's not the same as hemolysis, because the reticulocyte count is low. Excess hemolysis. Did you know that copper causes hemolysis? Copper? Yes. People with Wilson's disease can get hemolysis. Really? Yeah. Copper deficiency looks like B12 deficiency. Copper deficiency can cause a marrow production problem, copper deficiency. And copper excess burns the cells. There's a patient with an increased bilirubin, LDH, and reticulocyte count. Decreased platelets. Ooh, schistocytes. Ooh, that's hemolysis for sure. High bilirubin, high LDH, high reticulocyte count. That's hemolysis for sure. Now, but there's also renal. This is like let's see. Oh, this is like a hemolytic syndrome with uremia. This is like a hemolytic uremic syndrome. What do we add? Do steroids help hemolytic uremic syndrome? This is hemolysis, renal failure, and low platelets. Hemolysis, renal failure, and low platelets. Eculizumab help with that? Eculizumab, what the hell is that? Eculizumab. Eculizumab is a monoclonal antibody against C5 and the complement cascade. Giving platelets is definitely the wrong answer that we're looking for. Giving platelets does not help. Giving platelets actually can make it worse. But eculizumab is an antibody against complement C5. Eculizumab is an antibody against complement C5. And if your hemolytic uremic and CTP is not from E. coli 015787, but is more idiopathic, eculizumab can block the activation of the complement system. Eculizumab can block the activation of the complement system by removing complement C5. All forms of hemolysis of high bilirubin, high LDH, high retics, and low haptoglobin, all of them, even the extravascular ones, even the ones in the liver and the spleen, even the extravascular ones can decrease haptoglobin. But let's look at and see what's different and unique. So we're back at a famous Conrad Fisher table, which is to say all of these diseases are forms of hemolysis. Autoimmune hemolysis, also known as warm immunoglobulins, IgG. So warm antibodies, cold antibodies, or IgMs. Is it TTP and hemolytic uremic syndrome? Is it G6PD deficiency? Is it paroxysmal nocturnal hemoglobinuria? Is it hereditary spherocytosis? Every one of these has a high LDH, high reticulocyte count, high indirect bilirubin, low haptoglobin, and only a few of them have schistocytes and helmet cells. So autoimmune disease, 40% of the time we never get a diagnosis, but it is all the autoimmune diseases, collagen vascular, lupus, rheumatoid arthritis, and many medications like penicillin, sulfa drugs, allopurinol, phenytoin, rifampin, cause hemolysis, penicillin, sulfa drugs, allopurinol, phenytoin, rifampin. What are the medications that cause allergic interstitial nephritis? Allergic interstitial nephritis is caused by penicillin, sulfa drugs, allopurinol, phenytoin, rifampin. Penicillin, sulfa drugs, allopurinol, phenytoin, rifampin, quinidine, and lamotrigine. What are the things that cause Stevens-Johnson syndrome? The allergic reaction known as Stevens-Johnson syndrome, or toxic epidermal necrolysis. Necrolysis, TEN. Why is it penicillin, sulfa drugs, allopurinol, phenytoin, and rifampin, quinidine, and lamotrigine? So isn't that the point now? Isn't the point that so many of the things that cause the autoimmune hemolysis are the things that cause allergic interstitial nephritis, are the things which cause drug reactions to the skin? Because some drugs are allergenic and provoke antigen-antibody responses everywhere. It could be the skin, it could be the red cells, it could be the kidney tubules. At the same time, have you ever heard of a beta blocker-induced hemolysis? Beta blocker-induced nephritis? Beta blocker-induced skin reactions and rash? Have you ever heard of a calcium blocker hemolysis? A calcium blocker rash? Have you ever heard of an SSRI hemolysis, an SSRI rash, SSRI interstitial nephritis? No. That's actually the point. Certain substances can be allergenic everywhere, and certain subjects are not allergenic anywhere. It's like people. Some people can be chill, happy, relaxed, and friendly no matter where they are, and some people can be annoying on 5 continents. The best initial test is a Coombs test, and direct and indirect Coombs tell basically the same thing. Just like any allergic reaction, the best initial therapy is glucocorticoids. You stop the steroids and it recurs. You restart the steroids and it gets better. You stop the steroids and it recurs. You restart the steroids and it gets better. It doesn't go away. It keeps going back, and it becomes like ITP, immune thrombocytopenic purpura. Immune thrombocytopenic purpura, remove the spleen. Ooh, IV immunoglobulins. You mean it's a bit just like ITP? That when it's acute and severe and the steroids are not working and you're trying to transfuse them, and the problem is even despite transfusion and steroids, the hemoglobin still keeps dropping? The answer is immunoglobulins, intravenous immunoglobulins. What's the fastest way to raise the platelet count in ITP? Intravenous immunoglobulins. The fastest way to raise the platelet count in ITP. Now, Epstein-Barr mycoplasma causing cold agglutinin disease. What's the difference between a cold agglutinin and a cryoglobulin? What's the difference between a cold agglutinin and a cryoglobulin? And the answer is they are the same. They are the same in terms of being IgMs. Cold agglutinins and cryoglobulins. They are the same in terms of neither of them is treated with steroids, cold agglutinins and cryoglobulins. They are the same in terms of both of them are diseases that attack tissues that are normal. They're both IgMs. Neither gets better with steroids. Neither gets better with splenectomy. So what's different between cold agglutinin disease? What's different between cold agglutinin and cryoglobulin? Cold agglutinins is only a cause of hemolysis, and cryoglobulins causes glomerulonephritis. Cold agglutinins is mycoplasma and Epstein-Barr, and cryoglobulins is hepatitis C. Cold agglutinins are treated with rituximab. Cold agglutinins can be treated with rituximab, and cryoglobulins is treated with treating the hepatitis C. So let's take this table that you have in front of you in your book in your PDF. And let's go through the things that make you able to answer the questions. What's the most likely diagnosis? Spherocytosis, hemolytic uremic and TTP, G6PD, and PNH. Okay. So the first thing is hereditary spherocytosis. It's the only one that's chronic and lifelong enough, so they'll either give you a family history or they'll tell you there's a big spleen. It is in a way like sickle cell disease. It's a chronic compensated hemolysis that has a chronic compensated high reticulocyte count, but unlike sickle cell disease, the spleen is big because that's where the spherocytes get destroyed. The best initial test is that you have a microcytic anemia sometimes because the spherocytes are a bit small. But the other thing about this is osmotic fragility used to be the most accurate test. Now it's the eosin 5 maleimide. Eosin 5 maleimide, and that's new, that's different. All of these forms of hemolysis might do well with some folic acid replacement, but hereditary spherocytosis, since it's chronic and lifelong, gets folic acid all the time. And if there's episodes of bad and recurrent spherocytosis and hemolysis, just like a person who has bad and recurrent autoimmune hemolysis, we're going to do a splenectomy. Hemolytic uremic syndrome and TTP are really two variants of the same disease. Hemolytic uremic and TTP both cause you to have renal insufficiency. Both of them causes you to have a low platelet count. Both of them will have a positive intravascular hemolysis, a smear. If it's not from E. coli 015787, which is secondary to an infection, eculizumab is the therapy so that you remove complement C5, which can be attacking the cell in hemolytic uremic. The key issue that they're going to ask you is, if it is from infection E. coli 015787, don't give antibiotics. If the platelets are low, don't give platelets because giving platelets makes it worse. And besides eculizumab, if either of them is severe, we use plasmapheresis because we're replacing a DOMS13. We're putting on a DOMS13. We're restoring a DOMS13. G6PD, the most common cause of hemolysis, is not permaquin, not dapsone, not favabeans, permaquin, dapsone. In fact, the most common oxidant stress is, in fact, an infection. Now, at the beginning of G6PD, when there's hemolysis, you're not going to see a low G6PD level because the most deficient cells will have been destroyed. So the answer to the best initial test is going to be Heinz bodies and bite cells. Heinz bodies, blister cells, and bite cells. Heinz bodies, blister cells, and bite cells. Most accurate test, wait 2 months and do a G6PD level. The treatment for G6PD, there is no particular treatment for it. It hurts when I have oxidant stress. Don't have oxidant stress. It hurts when I have an infection. Don't get infected. It hurts when I have primaquin as an appetizer, fava beans, a main course, dapsone for dessert. Don't do that. Eat Italian. Paroxysmal nocturnal hemoglobinuria. Although it says the word paroxysmal nocturnal hemoglobinuria, your question is going to describe dark early morning urine. Although it says paroxysmal nocturnal hemoglobinuria, the key to the diagnosis is going to be, it'll say a pancytopenia, or it will describe clots at strange places. Not DVT and PE only, but things like Budd-Chiari, hepatic vein, portal vein thrombosis, cerebral vein thrombosis. Why you got a cerebral vein thrombosis? Up there? Looks like a subarachnoid, but the CT and the LP are negative. You get an MRV. Portal vein, hepatic vein thrombosis. That's a key one. It'll want you to know, our boards want us to know that PNH is associated with aplastic anemia. They want you to know that PNH is associated with the ability to develop acute myelogenous leukemia. They'll want you to know that paroxysmal nocturnal hemoglobinuria is a clonal stem cell defect associated with leukemia, aplastic anemia, leukemia, aplastic anemia. It's a stem cell defect. The best initial test is basically flow cytometry, a form of flow cytometry for PNH. Remember, it's a cell sorter flow cytometry, cell sorting, CD55 and 59 specifically. The wrong answers will always be sugar water or sucrose hemolysis and Ham's test. Those are old. We treat PNH by giving transfusions and steroids. Why do steroids work? Nobody's exactly clear why steroids works for this. The biggie for you is that PNH is the attack on complement that won't get off the cell. Complement is prematurely attacking the cell. So we use a drug like eculizumab that prevents the complement from attacking the red cell in PNH. So eculizumab. And they say, since you're removing complements, since you're damaging the complement cascade, you're going to use meningococcal vaccine before you use that medication. This is a lot of content into this table, but I hope you'll see it like this. Once you accept that they all have a high LDH, high bilirubin, high reticulocyte, low haptoglobin, and the intravasculars have schistocytes or helmet cells, fragmented cells, then there's only a few words you need to know for each. The new thing, hereditary spherocytosis is not diagnosed by osmotic fragility is the most accurate. The most accurate is eosin-5 maleimide. PNH is associated with leukemic disorders, strange thromboses, and eculizumab is a treatment to remove complement. There you go. What will tell you if it's spherocytosis? Big spleen. What else? Recurrent, big spleen, recurrent. What's the best initial test in spherocytosis? Is a smear seeing spherocytosis and eosin-5 maleimide. The most accurate test, eosin-5 maleimide, what you do is you give folic acid, and if it recurs and recurs, remove the spleen. The therapy here, transfuse and folic acid and remove the spleen. This is schistocytes, helmet cells, and fragmented cells. This is also known as microscopic angiopathic hemolytic anemia. This is characteristic of TIC, DIC, TTP, hemolytic uremic syndrome. Low platelets and intravascular hemolysis and kidney injury is hemolytic uremic syndrome. If you add fever and CNS problems, especially in adults, it is thrombotic thrombocytopenic purpura. The test is the test, besides the smear, besides what we say on the slide here, the test is a decreased level of ADAMPS 13. ADAMPS 13 is the enzyme that breaks up von Willebrand's factor. It's the enzyme that breaks up von Willebrand's factor. In TTP and HUS, don't use platelets. Do use plasmapheresis, and for HUS, not from infection, use eculizumab. What's the most common cause of G6? Most common hemolysis? The most common precipitant is not lead. Yes to infection. Not lead. Yes to infection. Now, the best initial test is Heinz bodies and bite cells. And the most accurate test is you wait 2 months and then get the G6PD level. Treatment is folic acid and avoid stress. So for spherocytosis and G6PD, there's really not anything specific you could do. You have folic acid if it's recurrent hemolysis. And this is a bite cell. Heinz bodies and bite cells. PNH presents with dark urine in the morning. And PNH gets clots in strange places. Hepatic vein, portal vein. What's different on CBC? Pancytopenia. The most accurate test is flow cytometry for CD55 and 59. And you treat with steroids and eculizumab. Bone marrow transplant, which we didn't say before, is the only curative option because since this is a pre-leukemic syndrome, the only way to get rid of that clonal stem cell defect is to transplant the marrow. A woman who's pregnant has got a hematocrit that's low, low platelets, hemolysis, elevated liver function tests, low platelets. Hemolysis, elevated liver function test, 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 low platelets. Now, at 37 weeks, you deliver the baby. When it's earlier than 37 weeks, let's say it's 28 weeks, 29 weeks, you would give steroids. Patient with HELLP syndrome. Oh, 30 weeks. I don't want to deliver a baby that premature. 30 weeks. I want to give her some steroids. Then I can deliver the baby. Steroids, wait a little while, then deliver the baby. Patient with increased LDH. So when it's at term, after 34 to 36 weeks, after 34, 36 weeks, then you can just deliver the baby. But if it's earlier, then what you'll do is give steroids for the fetal lung maturity. Increased LDH, increased bilirubin, Coombs positive for C3. But Coombs negative for other things. Just for complement. Coombs positive for complement. What's Coombs positive for complement only? But not for IgG. Coombs positive for complement, but not for IgG, is cold agglutinin disease. And cold agglutinin disease is treated with rituximab. Which hemolysis is more common in men? Not warm. Men are not particularly more warm. Men are not particularly more cold. Men are not particularly rounder. But G6PD, it's also saying which one of these is X-linked. The other one here that's X-linked is G6PD. The reason we gave you the table for the hemolysis and then separately is because it's difficult. It's a pain in the ass. Hard to remember hemolysis. Now you got it. Hard section, but it's not going to change next year. See you soon.